out of here and y'all can start your next class or go home. So, I wish. Okay, so we went over this. The big things from here that I'm going to ask you, because I know these slides look when you start to see charts, and a lot of these are going to appear when we're in Pharm 2. So make sure that on this you're looking at the things that I have bolded for you so that we can kind of hone in on the bigger ideas of a lot of these things. Some of this is more detailed than what you need to know, right? So if I ask you something, it's going to be the big ideas like, oh, if you had a very high potency, how long are you using it for? No longer than 2 to 4 weeks. If you needed to use it for a longer period of time, then what are you looking at? Maybe a medium or a low potency steroid. If I have an occluded area, what am I looking at using? I'm using a low potency steroid. So like the bigger things that you see me like putting, oh, you have a pregnant patient, you have an elderly woman, those things that are bolded are where I need you to draw your attention to, okay? And remembering which potency these medications are. So I could just give you the name of one of those steroids and say, hey, what do we have for this? And then you're gonna be like, oh, that one is a high potency. Oh, that one is a low potency. These are the stipulations, okay? All right, so our next slide that we have, again, sorted in that very high, medium, and low potency. This is just giving you some examples of the medications that fall into those categories so that you're seeing it on the same slide. The same kind of principles that we've already talked about before when we were looking at both of these, right? So reserving for your resistant areas, your resistant conditions and your thicker skin areas, and then the same limitations that we were talking about. And I've verbalized this to you, but this is just on the slide to say, hey, if you need longer therapy, you can do that pulse dosing or give them that high dose steroid, right, for a week, take them off, put them on one of those steroid sparing things that we had depending on what their condition is. So that's, again, telling you the same thing that we already talked about. This we said already, so both of these less than 3 months, right, 3 months or less. And then your low potency, remember we can use those for a longer period of time. We like those in our more delicate areas, okay? You're growing your face, your skin folds, things like that. Safer for our long-term use or our larger areas. And then when you see your intertriginous area, see there's words, y'all, that I'm just not, it's worse than drug names sometimes, y'all, these terms, our medical terms. So again, this is just a summary slide of the things that we've already talked about. And then it's giving you some conditions that you can also see. But again, we talked about a lot of these conditions in the derm lecture. So you're just seeing us using the same things again. It's just summarized on a slide. Okay, so there's nothing new on this table. But again, I just bolded the things that were more important that should stand out to you that you've seen several times throughout the lecture, okay? When you look at this, you also see that as the potency increases, think about more difficult diseases to treat, right? More resistant things that you're trying to treat so that you can remember, I need something stronger because it's not curing that disease state. It's not helping me. So now my medium potency didn't work. I went to a high potency, that didn't work. Okay, let me go to this very high potency. And sometimes that's what you may have to do. Okay, your dosing for your corticosteroids. All I need you to remember is 1 fingertip unit equals half a gram. What this means for you and why this is important to you, and I want you to remember this, is because when you order these medications, you need to make sure that you're giving them the right day supply for the amount of area that they need to cover. Now, sometimes people will give someone a 15-gram tube and they have this huge rash on their back. And they're putting, this is good for 30 days. That's not going to last that person 30 days. They're 6'5", right? They have a big bag, and not the bad big bag, a literal big bag, okay? So when you look at that, right, is that going to last my patient 30 days? No. So when the pharmacy tries to run that through TRICARE, through insurance, they're like, why is this person back? Refill too soon. They can't get it, okay? So that's why this is important for you to like visualize, okay, 1 fingertip unit is half a gram. How long am I expecting for this person to have to use it? How big of an area are they putting it on? And we have some of our ointments and creams that come in these big tubs, okay? So like you have the capability to order what they need, or you can order several tubes of something, okay? So 1 fingertip unit is equal to 0.5 grams. And then this is just something for you to use later. I'm not gonna ask you this way on the exam, but this tells you like a normal size on an adult of their face or their neck, their arm, their leg, so you can kind of see how much you should be prescribing to someone. And then you would, again, of course, base this off of the day supply that you're wanting to use, but this gives you like for a week if they were using it this many times in a week. So this is for you to use later. Great reference for you to not over prescribe or under prescribe when you're giving your creams and your ointments to your patients. FYI, this is the same exact principle, but it's for children. So again, something for you to use once you get out there and you practice. This is just saying, hey, the number of fingertip units. What's important about this is it's still based off of the adult, right? Because a child is not likely going to be applying their own cream to their body, unless they're an older kid. But that's why you see that it's based off of an adult fingertip unit. This is the same thing. This is just telling you, again, how many fingertip units are required to cover an amount of surface area. So FYI for you to use later. I don't test on this anymore. Refer to this picture. You're like, oh, you're using it on both legs. Oh, you're using it on one leg. This is how many fingertip units you would be using, okay? All right, now looking at our oral glucocorticoids that we have, this is going to be that potency relevancy chart. So remember when we were saying, when we were talking about our HPA axis suppression and we said prednisone, that was equivalent to 20 milligrams of prednisone. So this is the equivalency chart. And you see that, like, if I were looking at prednisone and I said, oh, I want to change this now to hydrocortisone, that dose now changes for that patient. It's not equivalent. So I can't go from 5 and say automatically that means that they take 5 milligrams of hydrocortisone. Not the same thing. I'm not making you remember any of these doses or any of that. All I want you to remember is short, intermediate, and long acting and which medications fall into which category. That's it. This may come up later, not what I'm asking you about. So short acting, which is something, right, when I'm trying to taper my patient off. So let's say I had them on an intermediate or a long acting steroid and I was trying to taper them off. Remember we said, oh, switch them to something that's short acting. So I could take you off of your dexamethasone or your prednisone and I could put you on hydrocortisone or cortisone, okay? So that's what this is saying. So your short acting, you have your hydrocortisone and your cortisone. Your long acting, you have your baby daddy, betamethasone and dexamethasone. I just remember BD, baby daddy, my baby daddy. Okay, long acting, he's there for a long time. We had a baby together. It's not going anywhere. And then intermediate is everything that falls in between. You know, I tell y'all, remember short, remember long, and then everything else is in between. I'm not going to make up steroids. Just be familiar with them, know those names, and you should be fine, okay? So just on this, you're only figuring out short, intermediate, or long acting, and that is it, okay? When you look at your short acting, this is just telling you different ways in which they are supplied. I am only asking you on this one, so cortisone, tablets and injection. What I want you to know is that you can use it for adrenal insufficiency. When you look at your hydrocortisone, again, you have several different formulations that are available. I want you to pay attention to your indication, so your clinical use again. So just go through these just that way. I'm not asking you about formulations. I don't want you to remember how they are supplied, okay? That's not important for me. Looking at your intermediate, so this was our everything in between, right? So your prednisone, your prednisolone, your methylprednisolone, your depot of your methylprednisolone. So you see you have acetate here. Methylprednisolone sodium succinate. This is the IV form that we have that we use whenever we're having those asthma attacks and we need like some immediate relief. That was your methylprednisolone. And then your triamcinolone. Now, I will not say, hey, we have methylprednisolone, and then I give you methylprednisolone sodium succinate and try to make you tell the difference between the two. Not doing that. If you know that you're using methylprednisolone for what, I want you to, like, we're going to go over this later, but your formulation for your methylprednisolone. If you see it and I'm talking to you about something that's like arthritis, gout, things like that, it's an IM injection. They're not taking it by mouth because they only have certain joints that are affected. So I need it to get to certain parts of their body, right? I don't need their whole body to be exposed to a steroid. Your IV, we already talked about our IV. Like these are immediate situations where I'm trying to get quick relief. And then I will say, oh, this one is an oral tablet, or I will tell you it is an IM, or I will tell you that it is a IV. And then you should know, hey, the IV, I need it quick. The injection, it's because they only have issues in certain places, and I'm only injecting it in certain places. Your tablets, this is called your, we call it a dose pack or a Medrol dose pack. It has the instructions on here. People do not read the instructions on here. Okay, so there's a card in here, and it tells them take this one before lunch, and this one before this time, and this one before this time, and there's like 6 in the first day, and it tapers them. But some people will pop out all 6 of those steroids on that very first day, and they will take them all at one time, and they will call and complain about all the side effects. And I'm like, did you take them at one time? Well, yes, they were on day 1. Yes, but under each one, it tells you when to take it in day 1, okay? So just make sure that you tell them to follow, like if you put on here, most of the time providers, so you all will not type out every single day what they're doing. Tell them to closely follow the package instructions and tell them it will be under each pill. It will tell them when they are taking it, okay? That way they can be like, oh yeah, I'm supposed to look at the inside of the package insert. Your triamcinolone, again, several different formulations that you have. Your prednisolone and your prednisone. These are 2 that I want you to pay attention to. And it's specifically what I've underlined because we have a lot of med errors and dosing errors for our kids based off of prednisone and prednisolone because they look and sound very similar to each other. You have prednisone that comes in tablets and syrups. And then you have your prednisolone that comes in injection and a syrup. So our peds patients use one of these. Typically, you'll see being prescribed. Most of the time, we do prednisolone. But what I want you to pay attention to is that you see, watch the dosing on your prednisone and prednisolone, equal potency, but multiple strengths of the syrup. So 5 milligrams per 5 mLs, or you have 15 milligrams per 5 mLs. Not the same thing. So when you are looking at, and when you go in Genesis and you select, make sure that you're looking at which strength you are selecting. Okay, same formulation, they're both syrups, but the amount that they're getting is going to be different. So if you said, oh, take 5 milliliters, but you didn't select the right one, now the dose that they're getting is going to be different because 5 milliliters of my 5 mg per 5 ml is not the same as 15 milligrams, right? Now they're getting only 5 milligrams in the 5 mLs, but of the first strength. But here, if I gave them 5 mLs, they're getting 15 milligrams. Okay, so pay attention. And if you put your weight, we can also help in the pharmacy because we're like, okay, based off of this weight and based off of this indication for this kid, we know that this is a mistake. So that's usually how we catch this. But I want you to be able to not be the PA where we're like, somebody might not know how to do math or read because you guys know how to do math and read. Okay? All right. It's questionable. No, just kidding. Y'all are doing good. Okay, so remember that this is the only one that I want you to watch out for because this is a huge med error that we see. Looking at our dexamethasone, long-acting, several different formulations that are available. You see all of these indications, a lot of these that we've already talked about before. The chemo-induced nausea, we kind of looked at that a little bit as well, but several indications, just be familiar with them and the fact that it is long-acting. And then the betamethasone, right, these are the same indications that we can use them for, okay? So just be familiar there. Nobody better miss that if y'all have a long-acting question. I'm still not done writing your exam, so I don't know that you have one, but don't miss that, or I'm going to be mad. Okay. Now, your corticosteroid antagonist that you have. Have we seen this before? Ketoconazole? Know that guy? Right? So we talked about ketoconazole, but we don't really look at it in this manner for the most part. So a lot of this is, what it's doing is it's blocking also the steroid production, which we need for our adrenal system, the gonads, all of the things. So yes, antibiotic, right? Antifungal. I said antibiotic. Antifungal, but helping with decreasing, right, the steroid production. Corticosteroid antagonist. That is the second part of its mechanism of action. So on this exam, if you are asked about the mechanism of action, yes, antifungal, but you see what it's doing here, the portion that I underlined, inhibitor of adrenal gonadal steroid synthesis, okay? You see that you can also use it in Cushing's disease as well. And then your adverse effects, adrenal suppression, right? Corticosteroid antagonist, adrenal suppression, gynecomastia, hypothyroidism, cholesterol, out of whack, lots of things. So a lot of the times when we look at that hypothyroidism, if you stop your ACTH, we can decrease the thyroid hormone production, and that's how we start to see issues with their thyroid. So if you have somebody that already has an issue with that, that's a problem. And because we said it inhibits the adrenal gonadal steroid synthesis, that's why you can see the gynecomastia happening in those patients, okay? Because it's disrupting how much testosterone is there, the estrogen levels get off, and now you have painful breast as a man. Not fun. Can happen in women too. Check on learning, 65-year-old female enters your clinic. She tried a new brand of deodorant 2 days ago and she complains of inflamed, itchy, red skin in her armpit. You decide to use a steroid to treat. Now, difference between this example and what will really happen. I will tell you what she has, but there's something else that's a clue in this that you don't even need to know what she has because I'm telling you where you're using it, right? The armpit. So what do I need to do, because I'm included? Yet, into the area, right? So what's my answer? A, right? So remember that, what else do I tell you here? She's 65 years old, right? So like you have two hints. When y'all are doing this, the name of the game, especially with steroids, is remembering where things go. I could also have given you a low potency steroid name here. So that's why I said there's several ways that chart that gives you all of those names, there's several ways for you to have to figure out where to use it, okay? Because it's not gonna say just low potency steroid, all right? And then our last couple of slides that we have, your mineral corticoids. We're gonna see these come up in other places, but we have our aldosterone and your fludrocortisone. When you look at your mineral corticoids, they're going to control a lot of the fluids in our body. So when we think about fluid control and how our body is handling or getting rid of, retaining or getting rid of water, we think about blood pressure, which y'all are going to talk a lot about, especially when you're in your junior semester and in some of our other blocks that we have of Pharm. So it helps with electrolyte imbalances, all of the things, and if I need to reabsorb or get rid of fluids. So when I look at this, these meds aren't something that we use a whole lot. So your aldosterone, not clinically used. So do you think I'm going to ask you about that? Nope. Okay, your fludrocortisone. This is what you'll typically see us use whenever we're talking about Addison's disease. So all I want you to remember is not used as a glucocorticoid. Clearly I told you it's a mineral corticoid. But it does have more activity, and it has the salt retaining potency that's a lot higher than the anti-inflammatory potency of it, right? So if we're looking at that, that means that we're using it a lot to manage that electrolyte imbalance that I was telling you about in the very beginning. So when you look at that, that's why we talk about this when we talk about adrenocortical insufficiency or your Addison's disease. So just know I'm using my fludrocortisone, which is a mineral corticoid, for Addison's disease, okay? I don't need you to know anything else from this. Spironolactone, eplerenone. So when you look at your spironolactone, these are going to be your mineral corticoid antagonists. These were your mineral corticoids, okay? So again, pay attention to the class in which these drugs go, because I could just simply ask you that. So your mineral corticoid antagonist, spironolactone, eplerenone, you're going to see these again when we talk about blood pressure again. So your mechanism of action, aldosterone antagonist. So again, just trying to compete in the renal tubules, which we're going to beat so much, y'all are going to get tired of hearing about it. So instead of potassium wasting that we could see with aldosterone, you have potassium sparing and sodium wasting that can occur here. So potassium sparing diuretic for CHF or congestive heart failure. And you can also use this for treatment of hyperaldosteronism. Your adverse effects, like I told you, it's potassium sparing. So if I'm keeping all of my potassium, now my levels went up. So hyperkalemia, and I told you that it's sodium wasting, right? So hyponatremia, you have your sodium here for hyponatremia. your K there for hyperkalemia. Polyuria, they're going to go to the bathroom a lot. It's essentially almost like you're giving them it is a diuretic. And we see this used a lot in our patients who do have CHF. That's when you'll typically see us use it because it does give mortality benefit to those patients. Anti-androgen effects. So again, the same things that we saw with our mineral corticoids, you're seeing here as well because of the androgen and those sex hormones being affected. So menstrual irregularities, the gynecomastia, breast issues. So think about sex issues. So your big idea here with your steroids are all going to be based off of, are you using the right potency of the right steroid in the right vehicle, right? Because my vehicle plays a role too, because it can help moisturize things, it can help dry things out in the right location for the right amount of time. Because I have limitations. If I'm high potency, my very high potency, you shouldn't be over those 4 weeks. I have a 3-month limitations, right? So that's what the big idea of you using steroids. You're going to see this again whenever you go through derm. These are your big principles that you have. Memory jogs here, go through them again, not the main things that you're focusing on, but the big ideas of what you need to make sure that you know. And that is it. So I am going to get to work on finishing. Let me know what else we can potentially move around, and if y'all need my help, I can figure that out. And I'll come over there for you guys really quick. If y'all have any questions, I'll hang out over there too.